We are so glad that you are here with us today. I am Robin Axel Adams. I am the manager of the Fairbanks Center for Medical Ethics. We just ask for those of you who are on site to please make sure that you signed in. When you leave, if you did not sign in, please do so that you can get your CE or CME credit. If you are off site, you should have someone at your site that has a sheet for you to be able to sign. But please know that you will only get your evaluations at the end of the year. This lecture is being recorded and broadcast today, so hello to our broadcast sites. We keep growing all the time in who we're broadcasting to, so we want to give a shout out to the IU Health hospitals. Arnett, Ball, Blackford, Bloomington, Jay, North, Saxony, Tipton, and West are with us today. The School of Dentistry is with us today, the IU School of Dentistry. The Peyton Manning Children's Hospital at St. Vincent's is with us, as well as Reed Health, so welcome. Just as a reminder to silence all of your devices, and if you need to return a call, please do so once you leave the auditorium. And Dr. Sinha has no relevant conflicts that she needs to share. All right, so let me introduce Dr. Shilpee Sinha. She is the service line lead for the Indiana University Health Palliative Care Services at the Adult Academic Health Center. She completed her medical studies at the Armed Forces Medical College of India and a residency in internal medicine at Overlook Hospital, a UMDNJ affiliated program in New Jersey. After completing a fellowship in hospice and palliative care at Beth Israel Medical Center, Manhattan, Albert Einstein College of Medicine, she joined us here at IU Health in 2006. Dr. Sinha started working as a hospitalist, providing primary palliative care and overseeing care for patients on the Yellow Rose unit, which was a unit for patients near the end of life. She additionally served as Associate Medical Director for the Ruth Lilly Hospice. Dr. Sinha transitioned to Palliative Care Department in 2011 when it was formally established. And during her years in service, she has been integrally involved in developing a robust inpatient presence here at the Academic Health Center, serving close to nearly 2,000 patients a year. And in her current role as the service line leader, she's helping grow IU Health's palliative care footprint across the spectrum of care within our system. Dr. Sinha is a recipient of the IU School of Medicine's Aspire Scholarship from 2017 to 18. And her passion is caring for patients with serious illness and helping advance palliative care both at a specialty level and at a primary level. And so today we are here to help to celebrate with palliative care their 10 years that they have been in existence. And while this is all really fun, formal stuff about Dr. Sinha, I will also say that Shilpee is just a really fun and delightful person. And I know you will enjoy her being with you today. Thank you.
Get this on. All right. Can everyone hear? All right, perfect.
We can't advance, can it? Can't advance the slide.
Oops.
Here, let me pull this out.
Oh.
Maybe I will not touch it.
Okay, let's try now. All right, thank you, Robin, for that introduction. And thank you so much, everyone, for being here today. It gives me great pride and joy to be talking to you about palliative care and our journey specifically within IU Health. So actually, November is National Palliative Care and Hospice Month, so there's no better time to be raising awareness. And I think a lot of us within palliative care and hospice are aware, but just last week, a bill was passed by the House of Representatives called PACHITA, or the Palliative Care and Hospice Education and Training Act. If this bill gets passed through the Senate, it's going to have a huge impetus in growing training and educational resources across the nation for this much needed service. So let's just get started. So life is pleasant, death is peaceful. It's the transition that's troublesome. This quotation by Isaac Asimov beautifully captures the essence of palliative care. And if you take a look, this photograph was taken by my iPhone at 13,000 feet elevation in the Himalayan range. This amazingly beautiful scenery with these are pashmina goats, what cashmere sweaters are made of. Those are those goats. So it's easy when you're surrounded by such beauty to dwell on life philosophically and what quality of life really is. So some years ago, when I gave my first presentation, I created this slide half out of jest, but really to drive a point home. Sadly, this misconception still exists in a lot of pockets. And I'm going to stand here today and reassure everybody we are not the Grim Reapers. We are certainly not Death Eaters. And what we do is we have the absolute privilege of being invited in when somebody is nearing the end of life. And we have the skills to help care for them through that time. So before I talk to you about IU Health in particular, I'd just like to give a brief primer on what palliative care is for those of you who are not within the field. The Center for Advancement of Palliative Care has a very simplistic definition for palliative care services, and this is what it is. It says palliative care is special medical care for people living with serious illness. So as you notice, the emphasis here is on living. The focus is on providing relief from the symptoms and stress of serious illness, and the goal is to improve quality of life for both the patient and the family. Where did palliative care originate? So the modern hospice and palliative care movement was started by Dame Cicely Saunders, who you see here. She was a remarkable lady. She was a social worker and actually was so deeply impacted by the care she was giving to one of her patients dying from cancer. She did go on to do some nursing and medical school and actually founded St. Christopher's Hospice in London, which was the very first formal hospice home, and created an environment where not just empathetic care, but medical care was also provided. Her philosophy was, there is so much more to be done. Because we hear very often that when people are nearing the end of life, the terminology is used that there's nothing more that can be done. But actually, this is very true, that there is so much that can and should be done, that this philosophy grew and people realized the importance of it and then took this forwards. And interestingly, Dame Cicely Saunders, when she was nearing the end of life, actually died in her own hospice home and received excellent care over there. This is Balfour Mount. He is credited with bringing this movement to America. He was a Canadian urologist who saw a lot of urological cancers through his career. And he went and visited St. Christopher's Hospice because he was so inspired by Elizabeth Kubler-Ross's Death and Dying and reading up about that. He brought that philosophy back to his hospital in Canada and extended it not just for the dying patient, but for seriously ill patients upstream as well. So he's really known as the father of modern palliative care, especially in America. He's also said to have coined the term palliative care. And the word palliative comes from a Latin root pallium. Pallium means cloak. So the philosophy is that we cloak somebody's distressing symptoms. I'm going to share this model of where palliative care fits into a trajectory of disease. This is an old graphic representation. There are newer versions of it, but I share this version mainly because this was where it was conceptualized. If you were to take any serious illness and you think about COPD or a stroke or cancer, dementia, you just think about it. This is the point of diagnosis. And in the early part, what we focus on is curative intent therapies or life-prolonging care. There is some role for palliating or alleviating symptoms of a patient, but most of the therapies are to try to slow down the trajectory of that disease or to alter the course of the trajectory of that disease. The other part about this is that there are peaks and troughs in between. Anybody dealing with a serious illness will have phases where they get acutely ill, they need some more symptom management, they need attention further than what they do in their day-to-day lives. As the disease progresses, the window of opportunity for therapeutic benefit from these cures starts narrowing. But the need for palliation or treating those symptoms starts increasing. So the role for palliative care actually increases. And then a lot of folks have questions about how do you differentiate between palliative care and hospice. Because it's a bit beyond the scope of this talk, I'm not going to go too much into that, but what's important to know is that hospice is an elected benefit, and it is designed for people who are at the last 6 months of their life. There are 2 golden rules that I was taught in my fellowship. Number 1 is people have to have an expected prognosis of 6 months or less. And number 2 is they have to actually elect hospice. I think a lot of folks don't realize that just because we as clinicians feel somebody should be on hospice, it doesn't automatically make them accepting of it, because the philosophy in hospice care is that patients have to accept that they are now transitioning to a less aggressive form of treatment. They are probably not going to allow certain therapies like chemotherapy, surgeries, interventions to happen, and therefore they are choosing to focus more on symptoms and on comfort. Another very interesting thing in this model is after death. Most of us think that's the end of the story, but the philosophy in palliative care and hospice is that patients leave behind a unit of loved ones, and they need support, they need care. So bereavement is a very big part of this as well. Many times people ask, so does that mean that everybody needs a palliative care consult? That's not true. It's not feasible, it's not practical, and it shouldn't be so, because most patients have very strong relationships with their primary clinicians. So there are actually 2 models of care. One is the integrative model, which is the primary palliative care. That means all of us as clinical folks, as chaplains, social workers, as physicians, nurses, everybody who's caring for a patient should have some tools handy that they can provide support and they can provide comfort to patients. And then for those patients where you need a more higher specialized level of care, you have the consults or the consult teams. And that is the specialist model of palliative care. This concept is very important moving forwards, because we have to not only develop specialist palliative care, we also have to focus on overarching development of primary palliative care. So what do we do in palliative care? What are we really doing over here? The team itself is an interdisciplinary team, and we believe in total care of patients, not just the physical, but the spiritual, the psychosocial. Oftentimes, these become more important than even the physical symptoms that people are experiencing. So we are an integrated team, and we approach the patient as a whole. Every time you see us on the units and all, you'll notice that we are usually in a group, and we often have our chaplains and social workers with us. There are many occasions in which I find the medical role is minimalistic, and actually there's much higher role for our chaplains and social workers to help the patients. The specialty advantage per se, what we get consulted for, is twofold. One is enhanced communication, clarification of goals of care, and the other is symptom management. Anytime somebody talks about what is bothering a patient, whenever they present to the ER, or when you're taking a history or you're talking to somebody, nobody is going to tell you that I'm suffering from metastatic cancer or I'm suffering from a CHF exacerbation. What they describe to you is they have pain, they have anxiety, they're nauseous. These are all universal symptoms. So in palliative care, we use tools. There is something in particular that our team uses here. It's called the Edmonton Symptom Assessment Plan. Just like you're familiar with assessing pain on a scale of 0 to 10, we assess all these symptoms on a scale of 0 to 10. And the intent is not to necessarily get that symptom to a 0, because all of us who have met with patients know that sometimes getting that to a 0 means now you're in an abundant state. What we need to know is that what is a comfortable functioning number for you, and then how can we help alleviate those symptoms? How do we target some treatments and some medications or even counseling towards those particular symptoms, because if we are able to control these, you're already making the patient feel much better. The second thing I talked about that we do within palliative care is we are trained and skilled to have nuanced conversations with people about what are your goals. And what is the relevance of knowing all of this? A lot of times when we see patients, it's usually in a crisis. It's usually in an acute care setting. And even if it is in the doctor's offices, people don't really have the time, or they're not given that time to spend with patients to really understand what their value systems are. We're constantly treating diseases. We're treating a specific state, and we're targeting medications, or we're referring someone to someone. We do not take that time to actually understand somebody's value system, and does all the stuff that we're doing to them actually match up to what they want from their quality of life. There are several times where treatments become more burdensome than the actual disease itself. And this is very important to understand, because we may have the best intent. We tend to become paternalistic in telling patients, this is the next step, this is what you need to do. But if we are not taking the time to talk to them and ask them, what is it that's important to you, we will never be able to achieve what we have set out to do, is to improve their quality of life. So having said that, what is the purpose of a goals of care conversation is to understand what options there are, offer them some different kinds of scenarios, and then meet them where they are in trying to get the right treatments targeted to them. A lot of times patients are not willing to go through certain therapies. They have already reached a stage in their life where being on a ventilator may be too much for them, or having artificial nutrition is not acceptable to them. And that's okay. Patients should have that right to choose that. And fortunately, now our ethics and our laws allow that. And the best way to document that is, in Indiana, we have what we call a post form, and that's why I have this up here. If you go to that website, I would strongly encourage everyone in the audience to spend about 15 or 20 minutes at any point and spend some time looking at that website, reading through all of this. Not only is this helpful for people in the medical field, it's helpful at a personal level. All of us are going to have family members and loved ones, friends, who will be going through something in the future or even now. And unless we have the tools and the information to help them understand that this is a choice, you are allowed to tell people that I don't want this or I do want this, and then have that documented in a document that can actually be carried forward in a legal manner. That is the essence of healthcare. So we need to make sure that we're informed well enough so that we can then educate people. Very interesting fact, just last year in 2018, our teams at the downtown hospitals, which this is what we track, that's why I have that information, just the 2 hospitals alone facilitated over 400 post forms. That is incredible. That means 400 patients that our team saw actually were ready to make these choices and document them and wanted them honored. So think about that. How many other patients may not even have had the opportunity to talk about this and document all of that? And I'm not suggesting that other providers are not completing these. It's merely a reflection of the need for doing more of this. A second part of doing what we call an advance directive, because what is an advance directive? It is really just a written testament of a patient's preferences for medical treatment. As important as it is for them to have it documented in some form, either a living will or the post form or whatever be it, that's how important it is for you to identify a surrogate decision maker. So up until 2 years ago, there was, within the state of Indiana, no hierarchy. That means all first-degree relatives had the right to weigh in on what your preferences might be if you lost capacity. So I used to tell a lot of folks that imagine that, put yourself in that position that now you can't talk for yourself, and imagine your parents, brothers, sisters, adult children, all these folks sitting together in a room and trying to make medical decisions for you. Is that really what you want? Is that what you would want for yourself? And if you don't want it for yourself, why would you want that for your patients? Now there is a hierarchy, so that means there is a chain of command per se, where the spouse comes first and it's adult children and so on and so forth. It's not still as helpful, I would say. It is good, but it can also be counterproductive because sometimes the spouse may not be the person who you want making those decisions. They may be too emotional. You may have had some kind of life experience where they don't reflect your preferences the best. So make sure that you educate your patients about the need for having a surrogate decision maker and help them complete these kind of documents. They exist in the form of healthcare power of attorneys. In some situations, legal guardians are there. But this is available off the Pulse page, and anyone can help fill it out. It doesn't have to be definitely not a lawyer or a notary, and it doesn't have to be a physician. It could be chaplaincy, social work, nurses. You're able to help educate patients about the role of a healthcare representative and help them fill it out. It also is a very useful tool to start that conversation. It's a foot in the door. When you talk to patients about this, this is less threatening to them than talking to them about, would you want resuscitation or not? If you talk to them and tell them that who would be that person who you would like to nominate to make medical decisions if you were in a crisis, that starts that conversation because it makes people pause and think about such a scenario. All right, so let's start taking a look here on, I'm going to try and hold all these things in my hand. So the Center for Advancement of Palliative Care just took out its report of hospital-based palliative care grading, state by state. So this is taken from their report, and take a close look at where the nation stands. If you see, they've graded it as an A, B, C, and D. A lot of these dark blue states have higher than 80% or more hospitals with mature specialist palliative care programs existing. The lighter blue states have between 60 to 79%. Then this purplish color represents the 40 to 59% range, and then there are the D states, where you have 20 to 33% or something. So what I find interesting is they've also geographically kind of outlined all of these, and we are what you call the northeast central states, which includes Wisconsin, Illinois, Indiana, Ohio, and Michigan. And whereas Wisconsin, Illinois, and Ohio are still considered to be the A grade states, we have Michigan and Indiana falling within the B category. I don't know about you all, I don't like getting a B on my report card ever. So I really do think that there's scope over here for us to get to an A grade. And I think as IU Health, we are the largest footprint within the state, and that is a responsibility we shoulder, that we absolutely must elevate the state to a level where it does fall into that A category and give us all good grades. Taking a closer look here in the state of Indiana. Over here, this graph is from 2015. So with the passage of years and the development of programs, you can see that there is an improvement in the number of palliative care available staff members for patients in various hospital systems. And again, I keep talking about hospital systems, we'll come to that later, only because palliative care has actually developed more within the acute care setting because of the way the need was. There is new growth now happening outside of the hospitals where really it's needed in the community. We just don't have that kind of robust data still from all the centers. So that's why this is more depictive of where palliative care stands. So the state of Indiana, the dark blue is urban hospitals. This light blue is suburban hospitals. And then, of course, the rural hospitals are the most neglected, where there really is a dearth of palliative care presence. This is where East, North, Central was in comparison, and this is the national averages, still doing very poorly in the rural areas. This again highlights the current state. This is the 2019 report. And again, this is the East, North, Central, a little bit of improvement. Again, mostly in the hospitals that are 300 beds or larger. So the large hospitals are the ones that have invested more in palliative care programs. The smaller capacity hospitals still don't have as much. This slide talks to us a little bit about what we have in palliative care developed a concept. The Center for Advancement of Palliative Care has helped develop some metrics because it's a very qualitative service. And if we need to make a good evidence-based comparison for how people are performing in different hospitals, there are certain ways of doing that. And this is a very well-established manner of how we can see how many patients are we really able to touch. So the penetration number, the way it's calculated is how many new patients were seen by a palliative care specialist team compared to how many total admissions were made to a hospital in a given year as a percentage. And that really is what this is. So this report is from 2017. They had not published the 2018 reports, at least on the web for us to see. But if you notice, compared to 2008, the average penetration across all hospitals in the nation was at about 2.5. That's the mean. And then in about 2017, it was 5.3% patients. So there's growth, there's development, but let's take a look at the breakdown. If you look at the smaller bed hospitals that have palliative care consult teams, this is the less than 150 beds. This is 150 to 299 beds, and this is the 300 plus beds. This is an important concept to understand. The larger hospitals have a larger volume of patients coming in. The denominator is larger. Just to give you a snapshot, the academic center, that means university and Methodist combined, just last year had about ballpark 40,000 total admissions come into their hospitals. That's a huge number. So even if you have an existing team, by sheer numbers, you're not going to achieve such a high penetration number. And that's why the 300 plus bed hospitals, even though they are the ones that are most adequately staffed nationally, there's a 93% and greater established teams in them, their penetration numbers are somewhat lower, so 4.3 and 4.5. And again, because I have the data present for the adult academic center, I can very proudly say that our hospitals, despite having such high volumes, we were actually able to achieve 5.4% penetration in 2018. And we are way on target for doing a similar kind of touch for patients even this year. This is very important to know. And again, showing you the growth within our own hospital systems. This is the academic center data. A little bit of a brag on how we are able to help patients. When we first started our program and started tracking patients touched, this is where we started. In the first year, there was about 600 patients or so seen. As you see, this number kept increasing as we were able to get more staff on board and able to develop our teams better. This number has now, in 2018, we saw about 2,100 patients. And again, this is up until the third quarter, so we haven't got the data for the third quarter. We're still in November right now. So we're way on target for achieving those metrics. There's a gap over here, you might notice. So this tells a story. I purposely left this there. I didn't make an estimate and put it there because, as you can imagine, when you start a new program in a high velocity tertiary referral center where you see so many sick patients and you're trying to develop something new, there's a pent-up demand. And with that pent-up demand comes a sudden rush of people reaching out for help. Our teams, from the beginning when we started, and that story I will share with you in a bit. When we started our teams, it was a very small presence of a physician, one nurse practitioner at both sites, some part-time of social work and some part-time of chaplaincy. And the patients were always there. They had never not been there, but suddenly there was awareness. So people started consulting us. And the one thing we didn't know how to do was say no. So what did that lead to? Significant burnout. So what you don't know about this story is the attrition rate and the high burnout rate that exists in palliative care and hospice because of the nature of the work that there is. And if you add that on to a high volume, high intensity hospital, there is going to be attrition. So in 2014, sadly, we did not have the staff to collect data, and there is no data. That doesn't mean that we weren't there. It doesn't mean we didn't see patients. It's just reflective of our journey. This is a very exciting piece of data. This shows our outpatient consults. So we did not have a presence in the outpatient up until 2015. And our first clinic opened up in 2015. Dr. Lexi Torkey started a half-day clinic with the heart failure team because they were the ones who invited us in early and started seeing some patients in that setting. And since then, from 2015, we are now within the downtown academic center areas, up to about 11 half-day sessions in a week, which is phenomenal. And we are almost at 280 patients, new patients seen this year itself. That doesn't include the number of visits. This is just new patients seen. And the other interesting factor is that the number of referrals and actual patients scheduled for being seen was actually way above. It was about 400 plus. The reason we didn't see them is sometimes we get consulted so late that patients get readmitted. They may die before they even come to our clinics. Sometimes they get enrolled in hospice. So there is still a lot of room for us to start getting palliative care upstream. And a very quick look at what kind of patients we see. This is our demographics. This large area, this is by primary diagnosis. This piece of the pie is all cancer patients. This is heart disease, liver failure, pulmonary disease, and then there's trauma, sepsis, renal disease, dementia, non-specific, gastrointestinal, all those other illnesses. This is another interesting pie graph, which tells us who's really reaching out to us for help, who are our partners within the hospital that actually know to call us when they find that there's a patient who needs palliative care. It's the hospitalist service and the critical care service really who we partner with, which is kind of a natural fit because they really are the primary owners of a patient, if you would like to say that, within a hospital system. The system now has become that each patient has an intensivist or a hospitalist attached to them, and they are really the ones who are managing the care and responsible for inviting the right consultants in. And then, of course, these are small portions of all the specialists who may have built relationships and known to invite us in, and they know about palliative care services. And then this last little piece of data over here is just to give you a snapshot of, again, this is a national data taken from CAPC. This tells you a comparison in hospital sizes and what kind of staffing they have. So the dark purple are physicians trained in palliative care. This light blue is for advanced practice nurses. The green is for nurse coordinators. This is social work. This is chaplaincy. This is 2008 and 2017 in the hospitals with less than 150 beds. This is, again, the middle-sized hospitals, and this is 300 plus beds. It's obvious that the more staff you have, the more ability you have to increase that penetration. And again, the growth shouldn't only be top-heavy from physician. It has to be across the spectrum of the interdisciplinary team. Another really interesting factor is that all these data talk about 300 plus beds. Even within that group of hospitals, there's a huge range. Our academic center, for context, has 900 plus beds between University and Methodist. So that's a phenomenal volume. It can't be compared to a 300-bed hospital. And in addition to that, another thing that is well tracked within CAPC is the ability to penetrate and the ability to touch patients obviously is higher in the hospitals that have a higher staffing ratio. That's just logic. So they do have and track those kind of data as well, which is helpful for hospital systems to develop their teams in the future. This is a recent meeting that our team had, and I wanted to include this because when I first onboarded in this department, I remember we were not even considered like one uniform academic center. It was still somewhat siloed with University and Methodist, and there was just four or five of us within our department that we got to interact with. Last month, we had a session where the academic center palliative care group got together and did a lean process. And this picture was taken over there. And it just makes me so happy to see that we have a tribe. And if we were to include all the palliative care folks within IU from Bloomington and Ball and Riley and everywhere, I'm sure that tribe would be way bigger and is bigger. So, all right, now for the fun part of this talk. So that's the story of what palliative care is and what kind of metrics we track and what we're able to do. Let's talk about how we got there. I had to do a little bit of a scavenger hunt to find this little thing. Way back, for those of us who have worked here long enough, I'm not suggesting that I'm 80 years old, but still, this was a sign that used to be up on B6, the old building. It was called the Yellow Rose Unit. And this was a sign that was made when that first unit opened. I tried to take this picture, but what you may not be able to read over here is this was a list of donors that was started. And my administrative director, Jim Luce, actually reminded me that he was actually involved in getting this thing created. And I made sure that we have a picture of this just for posterity saved somewhere. All right, so now I'm going to share with you a little bit about this history. My children recently said something that really tickled me, that they were talking about something that happened in 1990 something, and they said, oh, you mean the 1900s? So, so in the 1900s, we did not really have formal palliative care. At the turn of the century, the Yellow Rose Unit was opened. I often joke that even though the Yellow Rose Unit has shut down at least 5 years ago, the ghost of the Yellow Rose Unit still roams around the hospital, because I have residents who were probably not even in medical school at the time that unit was formed who will still say, this patient needs to be moved to the Yellow Rose Unit. And I'm like, what? You know, it doesn't exist. There is a comfort unit, a smaller 5-bed cluster, which does provide similar type of care. But the Yellow Rose Unit was really designed for end-of-life care for patients. And it was a very, very helpful concept. There's a lot of inpatient palliative care units across the country that hospitals have developed, where they have a really nice setup even for hospice patients and non-hospice palliative care patients, where families can collect and they can spend some time with their loved ones, as well as the nurses are more skilled in that facet of care. So in 2006, because this is my lens of how I was gathering information, I finished my fellowship in Manhattan and I was about to move to Indiana, and my mentor called and asked about the availability of a palliative care physician for me in Indiana, where I was moving. And I'm not quite sure who he was in touch with, but what he was told and what I was told is, there's no palliative care over here. And that was kind of the end of the conversation. But what I didn't know was already happening at that time was, even though there was no palliative care, the Yellow Rose Unit was manned by Dr. Buran at the time, and he had apparently submitted a proposal to develop a formal palliative care program. It was not a very robust proposal. It did not really get picked up. But at the same time, what I didn't know was happening is that at Eskenazi, the first formal fellow had been hired, who's now the fellowship director, Dr. Lyle Fettig, a lot of you know him, but he had just been hired. And interestingly, Eskenazi was way ahead in that it already had a palliative care presence. Dr. Greg Gramos-Packer was already kind of a force over there, and he was developing palliative care expertise formally. So what happened between that proposal being sent and rejected and then? So Dr. Greg Sachs, who's in the audience right now, is our division chief, and he just moved over to IU around that time, and he had experience in geriatrics and palliative care. Interestingly, through that rejected proposal, senior leadership was made aware of palliative care, and they decided that this is something that is needed within IU. They wanted to support it. In turn, what that led to was the values committee got engaged, and Dr. Steve Ivey and Jim Lewis together met with Dr. Sachs. They had a lot of brainstorming done. This led to a series of high-level meetings, which I honestly cannot tell you how intriguing it has been for me to actually go through a list of those meetings and agendas, because Jim had actually saved a folder of those. And just to realize what it took to get to starting a formal palliative care program is pretty impressive. There were several people involved, and I won't be able to name all of them, but I think it really does tell a true story that it takes a lot of committed people to get something new, which hasn't been tested, which doesn't have a quantitative value necessarily attached to it, and how that got initiated. So there was a lot of high-level strategic meetings happening. In the meantime, what about our other hospital systems in the area? This is about IU, but what about the others? So Eskenazi, like I mentioned, already had palliative care in 1997. St. Vincent started its program in 2008. The VA started it in 2009. The VA is about 165 beds capacity. Eskenazi is about 300 bed capacity. And then the community hospital system started its program around 2009. What happened after IU agreed that, yes, this is something we want to invest in? How do you actually launch something of that caliber? And how do you make it robust? How do you make it evidence-based? So Sean Morrison is the current director for the National Palliative Care Research Center, and he is a geriatrician / palliative care physician at Mount Sinai. And he was brought in as a consultant. He was discussing the Center for Advancement of Palliative Care's handbook in program development, and there were some good strategic meetings about how a program should be built. And this in turn led to another set of meetings with Lynn Spriggans, who is a business consultant, and she develops programs for both geriatrics and palliative care, the operational aspect of it. So everything was done in a pretty systematic manner to lay out a plan, and that led to an operational strategy actually being implemented. In the meantime, already around 2008, there were some early clinical seeds of a formal specialty level palliative care happening. It was just more directed towards, a nurse who was interested in that area and was helping with patients' pain management and end-of-life care. But the formal department still had not started. In 2010, after all these strategic meetings, a vision statement was laid out for palliative care. And then finally, IU Health, IUHP, Division of Medicine, all of that got together. They committed to developing palliative care expertise. That too, even though the vision statement was laid out for the academic center, for the pediatric program as well, because I'm from the adult side, we cannot ignore the need for palliative care in the pediatric population. So that was all laid out in that strategy, also expansion into the regional areas. But the first seeds were really at the academic center at University Hospital and Methodist Hospital. So subsequent to that, how did IU develop further expertise? In 2010, Methodist Hospital and University Hospital had its first hires of formal palliative care specialists and a team. Bloomington came next in January of 2012. Followed by that, it was IU Ball in January of 2013. Riley, even though this vision statement was written down logistically and the academic center adult side had already started, Riley didn't get a program invested in up until December of 2013. And a big shout out to our counterparts in the pediatric world. As much as we feel that we have a difficult job that we do, I have so much respect for our colleagues who deal with sick children and their families over there. They have a wonderful program doing so well, and their need just keeps growing and growing. Arnett was started in December 2017. IU West, which is falling under our service line, is just started its program in May of 2019. And then we have now got a presence in North, Tipton, and Saxony as well. We have a physician, Dr. Tanis, who's also here in the audience and has just started doing some palliative care straight out of his fellowship over there. So it's a wonderful asset we have. A little bit about what all we have been able to achieve between 2014 and 19. We've had inpatient, outpatient, anthem requirements have grown, joint commission requirements have grown. And then we just got together and laid out our vision statement, which really is, our goal is to have all patients across the state get access to palliative care. Then we are hopeful to develop home-based palliative care, use virtual health, also develop more regional expansion. This is our current state, where we are. IU Health's vision is to have healthy Indiana, which includes not just physical health, but emotional, psychosocial health. And that does include all of what we said. We have all of these clinical expertise. We have targets for home-based, facility-based, and virtual health developing, and we have education as a very strong pillar for growth. Speaking of our pillars for growth, this is a vision that we have laid out. If you can see, any program lays on not just the clinical expertise. You have to have some research and educational backing to actually develop a robust program. Fortunately, with our affiliation with the IU School of Medicine, we have been able to have a longitudinal growth of both sides. The clinical side is what I have mainly touched on so far, but beyond that, there's fellowship training offered through the IU School of Medicine. There are students that rotate. Just last year at our downtown hospitals alone, over 40 learners came and rotated through our hospitals. There's physician education, there's IU Talk, there's impact training for nurses. We just had an ISPEC training an hour ago with the chaplaincy spiritual care department. ELMS modules have been created. There's grassroots levels of teaching. Then there is the Respect Center, and faculty within IU School of Medicine is doing really good research on both advanced directive work as well as other palliative issues, supportive oncology and otherwise. Not just that, even in the community, there are faculty members who are leading the advocacy, the legislature. I see Susan over here. Susan was instrumental in getting the post form to Indiana and continues doing work for that. Not only that, even at a grassroots level, our faculty is holding community talks at libraries and churches and just spreading awareness. So just towards the end of this talk, where has this led us? I'm sharing this story about one of my very first patients because I didn't do outpatient work up until 2 years ago. I was heavily into just the inpatient clinical side. The ability for us to provide this kind of care across the spectrum is shown beautifully through the story of this patient. I first met her in the hospital. I was consulted through one of our hospitalist colleagues. This was an elderly lady who had a lot of advanced illnesses. She was a dialysis patient, a lot of symptoms. She had some hematological issues as well. We were called for what they call goals of care, as well as pain management. My first encounter with her was with her and her two daughters, lovely daughters, very attentive. They really didn't know what to do. They were struggling with their mother being sick all the time, and they weren't quite sure which direction to go. And so we started off with just managing her symptoms and starting some conversations about, what is quality of life to her and what would they like, what would they not like, getting advanced directive information. She was subsequently stabilized and discharged, and because we had the ability to see her in the outpatient, she became my clinic patient, and she was one of my first clinic patients, so that's why I remember her so well. And I remember through the course of the next year, she would come and visit me periodically with her daughters, always being fussed on. They were always like tucking her in and doing something or the other, having some banter amongst themselves, and we developed a really good relationship along the way. Just by minimal pain management, her quality of life had already improved. She was able to establish what she wants, what she doesn't want. We did a post form for her. Through the course of the year, I think she had a couple of hospitalizations, but mostly was able to stay home. And then finally, when that time came where she felt like she really had lived a good life and the dialysis was becoming more and more difficult for her. She used to struggle through each dialysis session. Her blood pressures would drop, and she just did not want to deal with that anymore. She called us in our office. And even without having to drag them all into the hospital or the office space, we were able to call our IU hospice counterparts, make a referral. They met her at home, and she died very peacefully, surrounded by her loved ones. And we received a beautiful thank you card from her daughters. And I cherish that till now because I actually saw this patient through that spectrum. And that truly is what we want to be able to achieve, is that we want to support patients. We want to support them in life and through death. This is a memorial wreath. A lot of you who may have crossed through our department may be familiar with it, but for those of you who are not, every year, the academic center sees about 1,200 or so deaths. Out of that, our team alone helps care for patients, about 400 plus of them. I would say about a third of our patients die. Most of them go on to live and they get discharged or they get rehospitalized at some point. But every time a patient dies, a level of engagement we have, that can lead to some level of burnout. So our team developed, with the help of one of our physicians who's now at the VA, in her fellowship, they used to do this more of a way of memorializing patients to help develop resilience, tying a ribbon in memory of a patient. We started doing this about 3 or 4 years ago, and this holds so much meaning. Every morning when we huddle as a group, we talk about any patient who may have died. We'll say a couple of lines about them, remember them in some way. Sometimes they're funny stories, sometimes they're sad. Sometimes you're like, wow, that was a difficult patient. But whatever it is, it gives us pause. It puts meaning in what we do. This is one of our wreaths. At the end of the year, as you can see, it's full. And each ribbon just symbolizes one life that we were fortunate enough to touch. I'm going to end this talk with this little cartoon that somebody forwarded to me. So Charlie Brown says, "We only live once, Snoopy." And Snoopy says, "Wrong, we only die once. We live every day." So Snoopy is wise because he's right. We do live every day, but he's also very wise in saying we die only once. That's why it's very important that we have quality not just in life, but in death as well. And with that, I'll end this talk and take any questions.
If you have questions, please wait for Kelsey or I to get to you with a microphone so that people offsite can hear them as well. So does anyone have any questions? Oh, yes.
Thank you so much, Dr. Sinha. I'm Brian Leland. I'm the Fellowship Director at FCME. I'm trying to sit down. Here we go. I wondered, do the vast majority of the referrals that you referenced for outpatient consults come from the outpatient setting, or are they inpatient referrals where you see the patient outpatient? And if so, obviously you showed a lot of metrics. Metrics always worry me because, for instance, I would argue it would be wonderful to be getting more outpatient referrals for outpatient consults, which could, if you will, compromise your inpatient metrics and how you are prepared for that, or planning to communicate how that's actually a good thing.
So if I understand the question, it's about like, how do we anticipate this whole balance of where our referral source comes from, and are they just the same patient circulating? And so this is a very good question, and it's an important discussion. I think the first thing I'll say to that is that we are nowhere close to meeting the demands of the population over here. So it's really not as relevant at this point where our referral source comes from. We would really love to see more referrals coming from the outpatient. Currently, you're correct. There are a certain fraction of them that we see in the hospital and then follow up in our clinics. But the nature of how we are allowed to expand, which means who are our partners. We have an embedded clinic model. So really, we borrow clinic space from specialties that are already interested in providing that kind of support. So for example, currently we have clinics in the advanced heart and lung clinic. We have liver. We have oncology is our large share of outpatient clinics. And then we have one primary care. We're hopeful for developing more primary care. So the referral source is obviously skewed based on where we are located and who is more integrated with us. But I can say this with safety. Again, going back to the comment on the suggestion is not that now we have to just replace the world with palliative care specialists. That's not at all true. What we need to do is we need to have the primary palliative care expertise, which again, through community, education, research, that all will develop that. And then we need to have access to specialty palliative care physicians to some degree wherever possible. So that is the bottom line. And we are so far from that vision right now that it's not too big a concern. Yeah.
Well, thank you, Dr. Sinha. I know we are really close to 1 o'clock, so if there are no other questions, I do want to put a quick plug in. As Dr. Sinha mentioned, Dr. Hickman has done a lot of work with Post, and she will actually be doing our lecture in January. So with updates to Post and on her recent research that she's been doing. And Dr. Gramelsbacher will also be here in April. So we have a lot of ties coming around. So thank you all for coming.